Good morning. I'm Dr. Anil Parikh. I'm Medical Director IPCA. Warm greetings from on behalf of IPCA on this second of the series of European Society of Hypertension CME series, which is organized, and it has been always endeavor of IPCA to participate in CME activities and spread CME education. And this started international speakers. We started, bringing to India after the launch of a low dose chlorothalidone 6.25 milligram and 12.5 milligram, the renaissance which we did. And then we had international speaker, JNC 7, Professor Aram Chobanian, Professor Messerly, and Professor Henry Black. And then we had always the guidance of Professor Venkatram in our endeavor. So today for this European Society of Hypertension meeting, where the guidelines would be discussed of 2023 guideline of the new guideline which they have come out with. It's a very extensive document as we discussed earlier, and very, very comprehensive coverage of all aspects of hypertension. I think this is the most up-to-date guideline which we have come across in on the management of hypertension. And now I would like to introduce the two chairpersons for this meeting. So can we have the slide of the chairperson, Dr. Grassi? Professor Grassi is president of the European Society of Hypertension Scientific Council in Milan, Italy. He is professor of internal medicine at Clinica Medica, University of Milano, and director of Clinical Media Institute of St. Gherardi Hospital, Monza, Italy. Director of Postgraduate School of Internal Medicine and PhD course of Public Health, University of Milan. Is vice chairman. He was vice chairman in 2002, 2004, and then he was chairman of in 2004 and 6 of the Working Group of Hypertension and the Heart of European Society of Hypertension. So right from the beginning, he has been there with the European Society of Hypertension, which completed just 20 years with this recent guidelines. 2003, the first guideline of European Society of Hypertension came out. In 2006 and 7, he was member of the task force of European Society of Hypertension and ESC 2007 guidelines on hypertension, and member scientific council of the International Society of Hypertension for the period 2008 to 12 and 2012 to 16, and member scientific council. So I think we can clearly see that he has been right there with the extensive contribution on the guideline. Next, we have from our own side, Professor P.C. Rath. Can we have his slide? Dr. P.C. Rath is Director and HOD of Cardiac Sciences of Apollo Hospital, Jubilee Hills, Hyderabad, as well as Bhubaneswar. Present assignments are Director and HOD Cardiology, Apollo, Hyderabad, as mentioned earlier. Then Fellowship in Interventional Cardiology from the University of Rouen, France. Training in Angioplasty from St. Luke's Hospital, University of Denver, Colorado. Then academic assignments which he has is Fellow of American College of Cardiology, European Society of Cardiology, Fellow of Royal College of Physicians, Edinburgh, Indian College of Cardiology, Faculty, Department of Cardiology, University of Rouen, France, Honorary Professor and Faculty of the University of Queensland, Australia, Professor Apollo Hospital Educational and Research Activity, Course Director and Co-Director, India Live, Hyderabad Live, and Course Director of Hyderabad World Society. He has various positions which he has held is President-elect CSI 22-23, National Convener, Interventional Council of CSI, Executive Body Member of the Cardiological Society, then Convener of the International Council of Cardiological Society of India, and President Indian College of Cardiology. And 2002 and 3, and Editorial Board of Indian Heart Journal since 2001. He has over 120 publications in journals of repute like Lancet, JACC, Cardiac Acceleration, Cardiovascular Diagnosis. So we have these two will be chairing today's deliberations. And to moderate today's sessions, we have none other than Professor Venkatas Ram. Can I have his slide, please? Yeah, he has been the ESH guideline reviewer of 2023. And currently, he is Director, Apollo Institute of Blood Pressure Management and Professor, Apollo Medical College, Hyderabad. I think in India, he does not need any introduction. All the medical community fraternity in India is widely aware of his contribution. We can say that he's If we say hypertension, then the foremost name in hypertension comes of Professor Venkatram. And at IPCA, we are very fortunate because he has been guiding us right from the beginning on hypertension and various our research programs as well. So he is director World Hypertension League in partnership with WHO South Asia region. He is director academics and scientific affairs of the Indian Society of Hypertension, professor of clinical medicine, University of Texas Southwestern Medical Center, and then director Texas Blood Pressure Institute, Dean McGuire University Medical School, Sydney, Australia, and founder member of the American Society of Hypertension, served as chairman, board of governors, ESH. So ESH, he has been instrumental right from the beginning, rated as one of the topmost hypertension experts in the world and listed in the Who is Who of the World book. Author of more than 410 publications and 9 books on hypertension. I think the publications exceed because I have had quite a few publications with him. Extensive lifelong career as a clinician, educator, and researcher in hypertension. And he has been awarded Padma Shri from the Indian government, which is a honor for his work on hypertension and prevention of heart disease. So with this background, I would request Professor Venkatram to kindly moderate the session further. Thank you.
Thank you, Anil. Good morning, ladies and gentlemen. I know that there are almost 2,500 people who have either logged in for the virtual or some of them are physically present. So welcome on a Sunday morning. I certainly want to express my gratitude to our European colleagues because it's 6:30 in the morning there, and suddenly the time changed a couple of hours ago. So, but obviously, being extremely honorable professionals, they're able to join at an early time. This program that we started recently after the annual meeting of ESH, because it was felt that the information that was assembled at ESH 2023, people who could not attend should have an opportunity to know what happened at ESH in some fashion, not in total. So we created these 3 modules for this year. This is second module, and third module will be at the end of November, and then we'll do few other modules in 2024. I just spoke to one of the organizers on the phone a little while ago. Due to the time change in Europe, the next meeting, the time for Europe will be at a decent, honorable, fully awake time. They're going to change it for the next meeting. So I just want to mention. So let's continue with the program. And I think we'll hand over the mic, the proceedings to Dr. P.C. Rath, who is kind enough to join despite this heavy work with CSI scientific program, almost daily, so much of work because he's in charge of the entire scientific program for the CSI, which is a major undertaking. And I'm glad that he's able to join. PC, please take over the proceedings from now, and thank you for your participation. Muted. PC, you're muted.
Yeah, good morning to all of you. I'm really honored to be part of this beautiful meeting. Thankful to European Society of Hypertension and IPCA Laboratory to bring this webinar on hypertension, and all the illustrious hypertension specialists from Europe are there. Dr. Venkatram is there. It will be, I'm sure, very, very educative and meeting. And the latest guideline of European Society of Hypertension 23 is going to enlighten all of us and change our views on hypertension management. With these words, I think we go ahead. I request the organizer to start the proceeding lecture. Thanks.
We request Professor Grassi to start.
Yeah, Dr. Since Dr.
Initial
Grassi has already been introduced, PC, he will start the program. Guido, please start.
I think that I can start, Venkata.
Okay.
Yes.
Just close it. Dr. Grassi will show his presentation.
Yeah.
May I have the chance to...
Just close this PPT.
The slide presentation, I
Yeah.
close it, yeah.
I hope that you will see my slide.
Yeah,
Yes.
we can see it now, you can go ahead.
Well, first of all, thank you for the invitation. Although it's early morning, it's a pleasure to be here with you and a large audience from India country. Well, my commitment will be to address the issue of the importance of heart rate as a potential marker of cardiovascular health and disease. And I will briefly touch 4 issues: the pathophysiological background for this link, current evidence, what we know about this, the possible limitation of the hypothesis that heart rate represents an important cardiovascular risk factor, and finally, briefly, the therapeutic approach. Well, this is an old slide, more than about 40 years ago, from the Framingham study, looking at the impact of different heart rate values. You can see starting from 30 beats per minute and going more than 100, both in men and divided by age, younger men on the left, older men on the right, and the impact on all-cause mortality. And you can see that progressive increase in heart rate cause a progressive increase in cardiovascular and total mortality. And particularly, the Framingham study showed that there is a close link between heart rate elevation and sudden death. This is particularly the case for men, but also for women, particularly in the post-menopause phase. And with Professor Mancha, we, about 2 years ago, we had the chance to look at different clinical studies which developed the concept of the importance of heart rate. These are the hazard ratio associated with an incremental increase in resting heart rate of about 10 beats per minute in the general population in different countries. And you can see that increasing heart rate, you will have an increase particularly in all-cause mortality, cardiovascular mortality. You can see here the data very clear with the Framingham study, heart failure, and myocardial infarction. And this was the case also in different patient population. These are data taken from the same paper in the on-target transcend study, patients with cardiovascular disease. In the advanced study, patients with diabetes mellitus, and in the CHARM study, patients with heart failure. And there is no question that, again, increase in heart rate about 10 beats per minute may particularly increase the risk of total and cardiovascular mortality, including myocardial infarction. Well, the data are also very clear for heart rate. This again are data from the Framingham study, and they did in this paper a very nice observation. They followed for a long time during the Framingham study the subjects, and what they found that if you have increased tachycardia, they increase heart rate values, therefore tachycardia in the initial phase or middle phase of the life, you will have later on more chance to develop particularly hypertension. Therefore, increasing heart rate is something which may favor development in future years of hypertension. And we have also data showing that there are some cutoff values for heart rate. You can see here the distribution of heart rate in patients with hypertension, and overall there is in these studies about 1/3 of the patients which have at rest heart rate values greater than 80 beats per minute, which according to also recent guidelines represent the threshold for cardiovascular risk. Well, why this? Well, these are data collected by our group a few years ago, looking at the possible difference in patients with hypertension in sympathetic activity measured by microneurography or evaluated by the assay of plasma norepinephrine in two groups of patients, hypertensive patients, with resting heart rate less than 80 beats per minute or more than 80 beats per minute. And this was the case for both clinic and 24-hour heart rate. And again, clear-cut evidence of a difference. People with elevated heart rate greater than 80 beats per minute show increase in sympathetic activity. And therefore, sympathetic activation is one of the factors which may be responsible for the link between increased heart rate and cardiovascular risk, because you know very well that sympathetic activation causes a number of adverse effects, both on the cardiovascular system, on the metabolic profile, and in general on the overall organism. Well, other data has been shown and similar to the one I just to show you. This is our data collected in people with chronic kidney disease, and again, elevation in heart rate is something very close with sympathetic overactivation. And the same is also shown in congestive heart failure patients, in which greater level of heart rate, progressive greater level of heart rate, are associated with greater level of sympathetic activation, meaning therefore that also in heart failure, the sympathetic overdrive, particularly when pronounced, may be caused by increased sympathetic influence to the heart and peripheral vascular system. Well, why heart rate represents an independent risk factor? Well, because there is evidence, we know very well, that heart rate elevation increase cardiac work and myocardial oxygen consumption, increase arterial wall stress, cause or associated with higher mean blood pressure values, decrease arterial distensibility, and this is something important for development of vascular atherosclerosis, kidney damage, close link with microalbuminuria, and finally facilitation of coronary plaque disruption. Well, the link between heart rate, as I mentioned, and atherosclerosis is very clear. You can see here that the magnitude and frequency of mechanical load, the alteration in the diastolic period may cause alteration in the wall stiffness, but particularly in endothelial shear stress. And this is something which may cause in the future development of atherosclerotic plaque and in future plaque rupture. And this has been shown in a number of studies. Look here, in this group of studies, they found that in multivariate analysis, the association between elevation in many factors and coronary plaque disruption, one of them is the increase in resting heart rate, which show a significant link with plaque disruption together with other factors, but for sure heart rate is one of them. This is because heart rate, this paper has data from Professor Palatini in Padua, in Italy, showing he looked at many studies on heart rate and found a close relationship with hypertension, with increase in body mass index, and also alteration, as I mentioned before, in metabolic profile, favoring metabolic syndrome and insulin resistance. Well, another study, I mentioned that many studies looked at the association between cardiovascular risk and heart rate. Some studies looked at the association between cerebrovascular disease and heart rate, and the link in this case was not found. Therefore, for suggesting that for a number of factors that we don't know clearly, while heart rate, as you can see in this slide, is closely associated with coronary heart disease, no relationship was found with cerebrovascular events. And this has been shown in this slide, and the link while the link between coronary artery disease and heart rate is very clear and pathophysiological motivated, the lack of link with cerebrovascular disease represents still something not clear. In hypertension, heart rate is associated with development and progression of target organ damage. I have no time to discuss this data, but for sure there is increased heart rate means increase, as I mentioned, arterial stiffness, left ventricular hypertrophy, presence of microalbuminuria, and neurological outcomes such as cognitive dysfunction. What we can do in clinical practice, you can see here a scheme of the effects of different antihypertensive or pharmacological agents, cardiovascular, on heart rate. And for sure, one of the most important drugs capable to markedly reduce heart rate is represented by beta-blocking agents, and during this meeting will be a detailed presentation of the importance of beta blockers as agents capable to reduce heart rate and cardiovascular risk. And this was the case also in congestive heart failure. Reduction in heart rate via a variety of drugs is capable to improve mortality in this group of patients characterized by heart failure. Heart rate lowering, this is a meta-regression, is associated with reduction in cardiac death. These are data from patients with previous myocardial infarction, and also in this case, you can see here that each 10 beats per minute reduction is estimated to reduce the odds ratio for cardiovascular death about of 1/4. Therefore, a very important impact on cardiovascular morbidity and mortality. Therefore, in conclusion, I think that we have evidence that drug-induced heart rate reduction may have together with anti-ischemic effects, protection on endothelial function, also reduction in heart atherogenicis, and all these factors may be associated with heart rate reduction. And this is, again, remembering in this slide, which refers to hypertension, the need to control heart rate, particularly when heart rate elevation is greater than 80 beats per minute. Thank you very much for your attention.
PC.
Yeah, video. Hello.
Yes, sir, we can hear, sir.
I think, can you go ahead for the next topic?
Yeah.
Yeah.
Shivam, just close this slide.
We'll,
Dr. Koots, for your slide.
I think you have to introduce Dr. Cruz. You have not done it. I think.
No,
Can I start?
Reinhold, yeah, you are ready to start. I think they showed your introduction slide. If they can put it back, at least so that the audience who are looking at it, take a look at it. Can somebody put Dr. Krutz's introduction slide on the screen? And then Dr. Krutz will give the talk.
Shivam, just push Dr. Koots' slide, please.
The introduction slide.
Yeah.
Yeah. PC,
Yeah.
if you introduce, yeah.
Yeah, I think it's my pleasure to introduce Professor Cruz. He's the immediate past president of European Society of Hypertensive Council, Berlin, Germany, Director, Department of Clinical Pharmacology and Toxicology, University of Berlin and Germany, and Professor of Hypertension and Clinical Pharmacology. And Dr. Cruz was awarded France Wollard Award by the German Society of Hypertension in 92, Young Investigator Award by the International Society of Hypertension in 96, France Gross Science Award for the German Society of Hypertension 2021. His main research interests include clinical pharmacology of cardiovascular drugs, clinical and experimental hypertension with focus on genomics of hypertensive target organ damage, pharmacogenomics of the safety of drug therapy. He is a member of the Scientific Council of European Society of Hypertension since 2015. He is currently the immediate past president of the ESH, co-chair of the 2023 European Society of Hypertension Guideline Task Force, and the president and host of the 35th annual meeting of the European Society of Hypertension Berlin, Germany in 2024. And I think with these introductions, I think we'll request Professor Cruz to deliver his talk. Thanks. Professor Cruz, you can start your slide, yeah.
Can you see my slide?
Yeah, we can
Yes.
see your slide.
Okay,
Please go ahead.
Yeah, thank you very much for the introduction, also for inviting me again. It's a pleasure to participate this morning. Good morning, dear colleagues. So hypertension, or the beauty, I always say, the beauty of hypertension is that it's relevant across the lifespan. Actually, if you talk about hypertension and pregnancy disorders, it starts already at a very early age. So it's very important. But I certainly will focus on hypertension in the old and the oldest old. The prevalence is the highest. Also, the risk is the highest in the old and the oldest old. However, the outcome data are largely based in middle-aged and older adults, and in young adults actually is relatively scarce if you look at recent meta-analysis. So when we looked into the evidence and formulated the recommendations, so we extrapolated for the young adults down to the age of 18 because we are focusing on adult, although we have some recommendations for adolescents and children in our guidelines. We have the age range of 18 to 79 years, and the definition of hypertension, initiation of hypertension is the same. It's at the threshold of 140/90 with a few exceptions only. And therefore also the targets are very important to discuss in this context. First, in the age range up to 79 years, according to our recommendations. So there we recommended that in patients 18 to 64 years of age, the primary goal is to really lower the blood pressure, always if well tolerated, below systolic 130, diastolic 80 millimeter mercury with a 1A recommendation. In patients 65 to 79, you see it's a little bit different with regard to systolic blood pressure. The first aim is to target below 140. Blood pressure can also be reduced to below 130, 80 if treatment is well tolerated. Blood pressure in all patients, hypertensive patients, should never be actively reduced below 120 and 70 millimeter mercury because of a marked increase of side effects, treatment discontinuation, possibly increase of adverse outcomes J-curve. And we have discussed, I think, this in the first module. The only new data with relevance to my topic are based on the STEP trial, an RCT recently published in 2021. The only new study that became available for us after the 2018 guidelines. And that study was done in 8,500 Chinese patients with hypertension. Inclusion age was 60 to 80 years. However, the mean age was closer actually to 60 rather than 80. It was 66 years, baseline blood pressure 146/82. Patients were randomized to intensive treatment, systolic 110, 129, versus 130 to 149, actually, something we would not do in this age group based on current evidence, but it was done when the study was designed up to this. So relatively high target blood pressure in the standard group. Primary outcome was a composite, as stated here. And the results for the primary endpoint is shown here. A clear benefit, significant benefit, with a hazard ratio risk reduction of 26% in those patients that were allocated to the more intensive treatment group that achieved the blood pressures 126.7 millimeter mercury compared to 135.9 millimeter mercury. Now, when we look into the benefits, the primary endpoint you have seen, also the study was not powered, to look, but obviously they did not formulate also a p-value for this. But if you, for the kind of interest, look into the different secondary endpoints and the phenotypes, stroke was reduced, acute coronary syndrome was reduced, and acute decompensated heart failure endpoints were reduced in the intensive treatment group, while death from any cause was not reduced, and death from cardiovascular causes was numerically, but not significantly, but that was not powered for this. So cardiovascular deaths may be reduced, although not significantly, but definitely outcomes, events, cardiovascular events are clearly reduced, and that's also important, obviously. If you look numerically, where's the greatest benefit? Actually, it's the reduction of acute decompensated heart failure. You see the hazard ratio of 0.27. We commented on this. Also, we have in the ESH now a new working group since a couple of years established now, focus on this important issue of older adults, and there's a key opinion leader in this field. The chair is Atanase Benetos. We commented on the STEP trial together with him. Clearly, it has provided new evidence to target the blood pressure below systolic 130 and older. However, the mean age, again, I would like to emphasize was 66 years in this population in the STEP trial. Frequent comorbidity is important to mention in the older adults were exclusion criteria, limiting the generalizability of the results. And however, we have to mention that the evidence for lower targets is still missing for patients for octogenarians or older because they were excluded. And certainly also for very frail patients, they are always included, dependent certainly patients that lose autonomy are excluded in all RCTs. So this also further limitation and a gap in knowledge. Now, the older and oldest olds are the largest growing population in Europe in several countries, including my country and other countries, also in Italy. And the only study, outcome study we still have is the hybrid study in octogenarians, including patients at the age of 80 years or older. The mean age in hybrid was 83.6. The range was 80 to up to 105 years. And they included patients with sustained systolic blood pressure over 160 millimeter mercury. That's also important when we formulate, a recommendation in our guidelines. Still, the inclusion in this only pivotal trial was 160 millimeter mercury. Target was below 150/80. It's important to remember. However, it's also important to remember that the study was terminated early because of a mortality benefit. And only a minority, actually, 1/3 of the patients had isolated systolic hypertension, which is the predominant form in this age group overall, when we look in the overall population. Also important to mention that 3/4 of the patients, at least at the end of the trial, were on combination therapy with a RAS blocker and a thiazide-like diuretic, an ACE inhibitor and a thiazide-like diuretic. So the primary endpoint was not significant, fatal or non-fatal stroke, because of early termination. Numerically, you see clear benefit, 30%, and it would have been possibly, very likely, positive, the result, when the study would have been conducted further, but it was stopped early because of the mortality benefit. So a mortality benefit, clearly, all-cause death even, 21%. Now, the most important phenotype, again, when we look into the secondary endpoints, again, heart failure. 64%, a profound reduction in the risk to develop heart failure, although, sometimes is a little bit of kind of an endpoint, which is a little bit weaker to determine, and there are different classifications. Now, in more recent studies, now we have usually used hospitalization for heart failure. So we recommend for the treatment strategies in older persons that the threshold for initiation up to the age of 79 years, 65 to 79 years, is also identical with the general adult population, 140/90. The primary goal is to lower blood pressure in the older persons below 140/80 millimeter mercury. And we may lower also below 130/80, also in this age group, if the treatment is very well tolerated. And this is an important subgroup, another phenotype, which we address also in the guidelines, which is the isolated systolic hypertension, which is very important, particularly in the elderly, very prevalent. And there are dedicated trials. And based on the analysis of the dedicated trials, actually, the primary goal is to lower blood pressure below 140/50. If you look at the trials, we have a 1A recommendation here. Nevertheless, also these patients, the blood pressure can be lowered below 140 systolic, even though when the blood pressure is already low at the systolic below 70 millimeter mercury. The reason for that is that in a recent meta-analysis, including 23 randomized controlled trials, even though they were not dedicated ESH trials, but when you look at the mean baseline blood pressure in those patients that had a systolic blood pressure of 140 or more, and the mean diastolic blood pressure was below 90 millimeter mercury, so these patients had possibly also isolated systolic hypertension. This meta-analysis was done by Matthias Brunstrom. It was also confirmed that lowering the blood pressure in patients with ISH below 140 and maybe even below 130, if well tolerated, is a reasonable approach. So there's a dilemma, obviously, of lowering systolic blood pressure in older patients with ISH in the presence of a really low diastolic blood pressure. It's a dilemma, a persisting dilemma in hypertension treatment. However, we recommend that we shall aim at achieving a balance between the best achievable systolic blood pressure reduction with diastolic blood pressure values that do not raise suspicion of reduced organ perfusion and affect treatment tolerability. However, aiming at systolic blood pressure control remains the primary goal to improve outcome, and if well tolerated, this goal should be also pursued in patients with a already low diastolic blood pressure. In the SHAP trial, for instance, patient with isolated systolic hypertension, a treatment-induced reduction of SBP was accompanied by a clear reduction of major cardiovascular events, despite the diastolic blood pressure reduction that brought its average value to 68 millimeter mercury. Now, in the older persons, 80 years or older, we recommend that the threshold for inhalation is evidence-based on the HYBET study, on the 160. However, when we look at the overall data, we recommend somewhat weaker with the 2C that also in the 140 to 150 range, blood pressure should be treated, hypertension should be treated, and also a reduction in the range below 140 can be considered in these patients. We have also more detailed recommendation, all of which I would like not to discuss. I have no time to discuss with you. You may look it up. We may discuss. One important is also, again, and is consistent with the previous one based on the hybrid trial, that withdrawal of blood pressure lowering drug on the basis of age, even when the patients attain the older age, is not recommended if treatment is well tolerated. That should not be done. And the reason for that is clearly shown in the hybrid trial again, because in the hybrid trials from the 3,845 patients randomized, 2/3 of the patients were actually on previous treatment, and only 1/3 largely were without previous treatment. Then they were randomized to placebo or active treatment. That means at the end, about 1,250 patients actually stopped treatment, and only less than 100 patients initiated treatment. So basically, a lot of the data, actually, the results is attributable to patients that actually stopped treatment, and it has clearly shown the benefit of active treatment. That means we should not stop. Clearly, it's also a take-home message from the hybrid trial in patients older than 80 years. To simplify the target, we have generated this figure with the green color, the corridor, in which we may lower blood pressure. It's clear it should be below 80 for diastolic blood pressure. But in summary, also in the older patients, at least 80 years old, we recommend that the blood pressure, if well tolerated, if the patients are fit, if they are not frail, can be lowered in the range, certainly below certainly below 140 and even 130 if the patients are not frail. In very frail patients that lost autonomy, treatment targets should be individualized. This is a study we have done in Berlin, for instance, again, coming to the issue of mortality. If you look at, observational evidence and community dwelling, older patients, the mean age in this study was 80 years. And we looked into patients that have controlled blood pressure below 140/90 as compared to patients not controlled. Actually, for mortality, particularly in those patients 80 years or older or with a previous cardiovascular event, you see there is an increased mortality in those patients in whom the blood pressure was controlled. But again, other phenotypes, such as the reduction of cardiovascular events and heart failure, as we have seen, is also very important, which was not analyzed in this study. One problem when we deal with the old patients is orthostatic hypotension that we are also addressing in our guidelines. Therefore, we also recommend, particularly in the older patients, at the first visit, certainly we should measure blood pressure in a standing position and regularly at each visit in the older patients and some other patients that have a risk for fall in blood pressure, for instance, because of neuropathy. At least 2 blood pressure measurements should be taken 1 and 3 minutes after standing. It's also important to mention again, although we have only shown in our graph how to measure office and out of office blood pressure, and we have not shown standing position, but it's important to mention and emphasize that it's always important to measure blood pressure at the mid-arm heart level, and that also applies when we measure blood pressure in the standing position. So the definition of orthostatic hypertension, there's a consensus, and it is defined as a decline in systolic blood pressure of at least 20 millimeter mercury and systolic or diastolic of at least 10 millimeter mercury after 3 minutes of standing. And we know this phenotype is associated with increased risk for cardiovascular events and mortality, also increased risk of injuries falls, particularly under treatment with vasodilators, and certainly it applies to the older persons, not to the young persons so much. Also in the hybrid trial, it has been shown that this is also an indicator for cognitive decline, either whether or not the patients are symptomatic or not symptomatic. It also indicates the risk to develop dementia in the older patients. Very often what we face, and in my clinic, particularly when as a clinical pharmacologist in a referral center, I deal with these patients with polypharmacy is also a problem, very important problem, which we have to address. We tried also to address it in the guidelines. And this is also very important, and together with frailty, we have to deal with. And this is a very busy table. I just would like to mention this. that we have also some recommendations how we can adapt the blood pressure lowering strategies in patients older than 80 years according to their functional or autonomy status in these older patients, and that has been put together by Atanase Benetos. So in summary, when we come back to the discussion of how far we should lower the blood pressure in the oldest old, including the patients at least 80 years old and patients with ISH, we also recommend that certainly we can lower blood pressure below 140 in these patients, and even below 130 if the patients are not frail, do not lose autonomy. If the patients are frail, treatment target should be, that's a take-home message, certainly, particularly in this age group, individualized. And the major benefit may be attributable to the reduction of heart failure and the prevention of heart failure in these older patients. With this, I would like to finish, and thank you very much for the attention.
Thank you, Dr. Kutz. I think we have one more talk, I think, by Professor Mancia. And can anybody show the slide of introduction slide of Dr. Mancia? Dr. Anil? I think Dr. Venkatram, will you introduce Dr. Mancia, or I'll introduce? He's a good friend in introducing. You are...
PC, please go ahead and introduce, because looks like
Yes.
Dr. Grassi.
It's my pleasure to introduce Professor Grassi Mancia from Italy.
It's a pleasure to introduce Professor Mancia. He is Emeritus Professor of Internal Medicine at University Milano Bicocca here in Milan, Italy, and he's worldwide well known as expert of hypertension and in general cardiovascular disease. He was president of European Society of Hypertension, International Society of Hypertension, chairman of European Society of Hypertension Educational Board, and he, more importantly for recent guideline, he is chairman with Professor Kreutz of the latest European guidelines on hypertension, and previously, in many years, in many editions, he was co-chair of this committee for guidelines performance. Therefore, Professor Mancia will address the issue in his presentation about the simplified approach to true resistant hypertension. Professor Mancia, please.
Hello? Okay. Can you see my slide?
Yes.
Okay. Thank you very much. Thank you for the presentation, and thank you for the invitation. I'll give you a report of what is written on resistant hypertension in the recent 2023 guidelines of the European Society of Hypertension. First of all, the definition. There is nothing new compared to the old definition. There is resistant hypertension as defined as a condition in which blood pressure is uncontrolled despite use of at least 3 drugs: a calcium channel blocker, a blocker of the renin-angiotensin system, and a diuretic, all of them at adequate doses. I cannot change. Sorry, but I have a problem in moving my slides.
You have to go to the presentation mode.
Hmm?
Go to the presentation mode.
In the, yes, okay.
Not to do the slideshow here.
Yeah. There. No. Yes.
Yeah.
Yes.
Okay. Okay. Well, how frequent is resistant hypertension? It's not easy to give an accurate figure of the prevalence of resistant hypertension. People with so-called apparent resistant hypertension may be just 1 out of 5 patients with a blood pressure elevation, but this does not really lead to an appropriate diagnosis of resistant hypertension. For doing this, you need to have 3 sets of information. One, ambulatory blood pressure should be elevated because there is evidence that with an elevation of ambulatory blood pressure, the risk of these people is particularly high. Then there should be, as far as this is possible, an assessment of adherence to treatment, and one should exclude non-adherence to treatment. And this is a source of clinical problems at the level of clinical practice. And third, there should be exclusion of secondary causes of hypertension. When this is done, probably resistant hypertension has a prevalence of about 5% of the hypertensive population. Now, 5% is a relatively low prevalence, but if we consider the very high prevalence of hypertension, then in absolute numbers, resistant hypertension is not a rare condition. Now, how should we treat it? The European guidelines give a first suggestion, and this is resistant hypertension is a difficult condition to treat. And therefore, doctors should consider, unless they are part of specialized centers or have a special expertise in hypertension, to have the help of a hypertension specialist of an excellent center on hypertension. Now, how treatment should be organized? First of all, the goal of treatment is not really different from that of the general hypertensive population. The first goal is to try to reduce blood pressure below 140/90 millimeter of mercury, because as Professor Kreutz mentioned, at this level, there is already a very marked reduction in cardiovascular events, at least if we consider data from the general hypertensive population. Unfortunately, similar data are not really available for resistant hypertension. I'm sorry, but can I stop 1 second because my battery is almost gone and I need to. Well, I'll try to go. Now, the second step is to treat, implement lifestyle changes. And you see that these are the usual lifestyle changes, but the most important of them is for sure reduction of sodium intake, because one of the most important pathophysiological aspects of resistant hypertension is sodium retention and water retention. So reducing sodium intake to less than 2 grams a day is perhaps the most important aspect of lifestyle changes for the treatment of resistant hypertension. Then it is very important to have an accurate history of the patient to see whether the patient is taking some drugs which may have a pressor effect or reduce the blood pressure lowering effect of antihypertensive treatment. And some of these drugs, they can be commonly used drugs, such, for example, even paracetamol, which is commonly taken as an anti-pain drug, may exert some anti
Is there a problem on our side, Sachin?
Sir, Dr. Mansia's, I think that laptop, the charge got over. That's what he's told.
Oh, is that the reason why the screen disappeared?
I think so, sir.
Okay, what we can do?
I can replug it and quickly come back.
Yeah, what we can do is let's wait. I'm sure that he's trying to plug it in.
Yeah.
If not, then we can ask
Tiny
Nair to do it, because he is in his library. I see all his books in the back. Okay.
I think, no, I think he's connected. No?
Well, Dr. Tini Nair is head of Department of Cardiology, Hospital Trivandrum in India, and he achieved many achievements during his scientific and clinical life. He is editorial board of a number of Indian journal related to hypertension and cardiovascular disease, and his publication number is about 90, with being author of 5 books. And it's a pleasure to give me the word for telling us a rationale for enduring clinical, for the uptrend in clinical usefulness of beta-blocking agents. Please, Dr. Nair.
So do you want me to start, or should we wait for? Do you want me to start, or should we wait for?
Ram sir, I think, sir, you can start.
I think, Tiny, you can start, and
Okay.
then when Dr. Mansia signs in, we'll just tell him that he can continue later on. We'll make up for the time.
Sure.
Please start.
My screen is visible, and am I audible?
Go ahead, please.
Can you hear me?
Okay, Dr. Mansia.
Yes, I'm sorry, I had a blackout of the computer. I will reconnect if this is possible.
Yeah, I think after Dr. Nair's, Tini Nair's lecture, you can start your things. By that time, you will be charged also. I think, Dr. Nair, I think you go ahead.
Okay, thank you. So our topic today is the discussion, clinical discussion. So I think I'm logged off again. Dr. Mansia is logged in. So I
Yes, yes.
finish and then we'll take. Not an issue.
Okay. So I can continue by saying that after having checked the assumption of pressure agents, then the second step is rationalization of current treatment of resistant hypertension. So one should attempt to simplify the regimen as much as possible, because this improves adherence to treatment. Now, rationalize a combination of drugs according to patients' demography and clinical characteristics, upgrading the doses of drugs. One of the most common causes of resistant hypertension is underdosing of the drugs. And then increase the dose of diuretics, because of the importance as a pathophysiological factor of sodium retention in resistant hypertension. And this can be done by using thiazide-like diuretics, in particular clothalidone, which can be used also in patients with the deterioration of renal function. And together with loop diuretics, there is evidence that concomitant use of diuretics at different sites of action in the kidney can increase the blood pressure reduction in patients with resistant hypertension. And then the final step is to add drugs to the 3 drugs by which resistant hypertension is defined, so go beyond the triple therapy. And here you have a seminal study, which is the Pathway 2 study, in which a comparison was done between different antihypertensive agents as the 4th drug. And the winner was clearly spironolactone at a dose of 25, but in most patients, the dose was 50 milligrams per day. And the blood pressure reduction with this drug was clearly greater than that with comparison drugs such as doxazosine and bisoprolol. Blood pressure was home blood pressure. It was not the classical clinic blood pressure. So this is, according to evidence, the first 4 drugs we should be considered. But we are far away from considering the use of spironolactone as the panacea for the treatment of resistant hypertension, because there are several inconveniences with the use of spironolactone. First of all, I think we have to admit that the Pathway 2 had some limitation. It was a 12-week study, so short-term observations. Patients with renal deterioration were eliminated from the study, were not included in the study. And this, of course, represented an advantage for the tolerability of spironolactone and limited in a way the final conclusion about its use. Then spironolactone, as you all know, have some problem, anti-androgenic effect. Then it favors hyperkalemia, although now this can be somewhat minimized by the use of patiromer or similar drugs that
Sachin, is it from our side or do you think it's his computer?
Yeah, Dr. Mansia said.
The network issues. It appears network issue. Yes.
Oh, okay.
I can also show the slides from my side.
But he is not off the line.
Yeah.
Okay.
Dr. Mansia, should I show the slides from my side?
No, he's I think not on the line.
Okay. You have his slides?
I have, sir.
Okay, maybe that's
Maybe he can connect with audio and you can show his slides.
Okay.
Just talk to him over the telephone. So that's an option whereby you can show his slides and Dr. Mansa can talk on audio. If it is possible. Just ask him. Somebody can call him up and find out what exactly is the problem.
Okay.
you think you can advance to the last slide he had? Then I'm trying to reach him.
Yes, sir. So is the slide visible?
Yes, you are seeing. You have to make it a PowerPoint show and then proceed to that slide.
This is the one.
Okay, yeah, they can, no, they are putting it back and they are going to show your slides.
Is it visible?
Sachin, your slides are visible, but you're on sorter view, slide sorter
Put it
view.
in a slideshow.
Yeah, I think you can go back to his last slide
Okay, sir.
and then let us see if we can come on audio. Kind of
Okay.
unusual, but unusual things happen always. Oh, okay. Okay, I think you need to go to the next slide. I think spironolactone. Okay, I think he can comment on it. Let me see. Okay, now let me see what is appropriate. Maybe I'll ask Dr. Reinhold this question because there is a question that younger population in today's scenario is more likely to have hypertension. How should a physician approach younger patients with hypertension? Because there is always a lot of attention to the elderly, but not much discussion on the young people because clinical trials are not done in the young. If Dr. Reinhold is still there, can he comment on it? Reinhold, are you on?
Yes, certainly. Yes. Yes.
Can you comment on how come
Yes.
the guidelines have not focused so much on young as you did in the old?
Yes. It was, I mean, that's the other age range related to my topic, but it's important increasing number of patients in your region and in other regions in the world, unlike some countries in Europe where the largest growing population are the young in other regions. In our regions actually is the oldest population. Nevertheless, I briefly mentioned, Venkata, that when, you know, for instance, when you look all the RCT data, and they looked at the age group below 55. First of all, the data are limited, and the mean age in this younger age group was actually about 50 years. So less evidence below 50 years, almost no evidence, you may say, in these patients. So we extrapolate basically when we do the recommendations also to the younger in the absence of RCT data. And I think and then the question of what is young, obviously it starts when we talk about even in the transition phase from the adolescents to the young patients is an ingredient population. The driving cause is clearly obesity in our region and your regions. So we have to develop further strategies and even do trials, but the problem is the patients are at very low risk. And you have long-term follow-up, and it would be difficult to do RCT. So we have to define new research ways, clinical pragmatic trials to deal with this. We do basically recommend the same approach, but we may do it a little bit different in clinical practice. There are some even young patients, young adults, even male adults that have different hypertension phenotype, also addressed in our new guidelines, like isolated systolic hypertension in the young is something different from isolated systolic hypertension in the older. So you have to do more phenotype. For this, in young patients, you have to do central blood pressure measurement in addition to normal blood pressure measurement, something like this. So to deal with the hypertension in obesity is a different issue. And the prevention is the most important, prevention is the most important, I think, take-home message. Dealing with the gain in weight gain, and obviously the advent now of the new obesity drugs is a very important tool, but it's also a kind of a problematic tool for several reasons. We may be stuck, but we may discuss. So the GLP-1 receptor antagonist and the new drugs that are coming to tackle the obesity problem should not deviate us from the most important approach is to prevent the development of obesity. And then there are some young patients which have a high heart rate, sympathetic overdrive. And then the question is whether even you wish to start treatment in those patients, for instance, with primarily the beta blockers rather than another drug. It's also not known, and that's the final comment, whether the RAS blockers, which are the backbone of the therapy, for several reasons that are also more capable of preventing the development of organ damage, probably are really whether the young patients will benefit actually from these drugs more than from other drugs, which has not been studied yet. So we have a lot of gaps still. In general approach, we have the guidelines is to extrapolate from the data we have in the older to the young, and we recommend more or less the same approach, but which is not optimal, I think. We should look at a little bit more detail in the younger patients, looking at different phenotypes, tackle the problem of obesity, sympathetic overdrive, and thereby select the drugs on an individual basis.
Thank you, Reinhold. So probably you already gave a correct, the available answer is that you're extrapolating the results.
Yes.
And, that seems to be a reasonable, acceptable scientific approach. There are two questions. One, I will ask Dr. Grassi very soon. Then one question, actually, I'm going to direct it to Dr. P.C. Rath. P.C., if you can unmute yourself. There are two questions that why so many young people are getting acute MI, very young people, and I personally know that you have taken care of patients in their teens and in 20s with acute MI. So can you comment on it, please?
You We see a good number of acute MI young in 30s. Some are just married, some are engaged, some are just going to get married. In fact, this is happening more frequently after the COVID. Previously, we have a sizable population of IT professionals who are very stressed and they don't do any exercise, take a lot of junk foods, and predominantly they are the people who are affected. But I see more after the COVID. You know, this last week we had 3 acute MI, 32, 30, one was 28. And none of them, except one was a smoker, others didn't have any considerable risk factor except that sedentary work. So I don't know what is happening, but I think definite increase in acute MI, especially in young, and more so after the COVID. Something to do with the vaccine or COVID infection.
Okay, thank you, PC. Then during panel discussion, I'm going to ask Dr. Prabhakar and Dr. Ray, what is and you also, who is the youngest person you have seen with documented MI? That's different. Dr. Grassi, Guido Grassi, when I looked at your slide where you put heart rate as central, looks like it is associated with every cardiovascular problem that we see. Every cardiovascular problem we see, it is poking towards it. Do you think it is a marker rather than a cause of cardiovascular disease?
Well, this is a very good question. I think, Venkata, that heart rate is both a marker but also a risk factor independent. There are many studies showing that independently on all other factors, elevation in heart rate is associated in the future with the development of particularly coronary artery disease, heart failure. I mentioned less cerebrovascular disease because for unknown reasons, but in general, I think that particularly taking into account the question that Professor Kreutz mentioned before, well, younger people with elevation in heart rate is something to be taken into account for drug treatment, but also for lifestyle intervention. Many of them have metabolic syndrome, obesity, and therefore some, or smoking per se. We know very well that cigarette smoking is something which increases not only blood pressure, but also heart rate, making sympathetic overdrive. Therefore, particularly young people, we have to take into account that heart rate elevation is an important risk factor and marker of cardiovascular disease, both.
Okay, all right. This is a very major topic because we will not. I don't think anybody measures heart rate unless patient says I have palpitations. Then we check. Otherwise, the patient might have 200, and we don't even check the pulse. But that's a philosophical discussion.
Do ECGs also? I mean, do ECGs also?
Yeah,
do ECG.
And if what we can, I'm going to comment on it, but because we need to proceed, there is no major trial that compared sacubitril valsartan combination for hypertension with standard therapy. It lowers the blood pressure, especially systolic blood pressure. It lowers it. Which component of this combination lowers the BP is not known because it has not been compared with the individual component. So it does lower the blood pressure, but what is there to offer in the absence of a comparative trial, I do not know. That is one. If somebody disagrees, we will.
I do.
You do, okay, please.
Respectfully, because you are a friend.
Sure.
Now, if I may comment.
Sure.
Sacubitril valsartan was developed as a antihypertensive drug
until
phase 2. Yeah? And then it was deviated to heart failure. And the phase 2 trial, published in The Lancet in 2010 by our friend Luis Ruilope actually studied 1,300 or whatever patients, and it was compared to the standard high dose of valsartan, 320 milligrams.
320.
And the placebo-corrected blood pressure lowering effect was almost 8 millimeter mercury superior to compared to valsartan, and also for diastolic blood pressure. So systolic and diastolic blood pressure are both lowered by sacubitril valsartan as compared to valsartan monotherapy. So, I mean, it's not an outcome trial. It's a short-term phase 2 trial, but it clearly showed it can lower both systolic and diastolic blood pressure. It would be a perfect drug for resistant hypertension, for instance, but it's not available. It has not been developed, and it's not approved in many countries. In some countries, you can use it. You are fortunate. You may use it. Also, the Chinese colleagues can use it. We cannot use it in our countries because it's not approved, will be not reimbursed.
Right. Only problem, Reinhold, is for resistant hypertension. If the patient is already on a RAS blocker,
yes,
then you are giving this combination which has got a RAS blocker.
Yes.
That's going to be...
It has not been studied in the context of I agree. But I mean, based on the phase 2 trial, we can argue in the general hypertensive population, you have a significant additional systolic and diastolic blood pressure lowering effect. I would assume it applies also to resistant hypertension patients, based on my personal experience also,
What we can do is that Prabhakar has brief comment, and then I want Dr. Tiny Nair to proceed with his talk. Then we will see what happens in the available time. Please, Prabhakar, please, one comment, and Tiny Nair, be ready.
The comment was on sacubitril valsartan. There is a meta-analysis of the global studies and the Asian data. And the Asian data has clearly shown that sacubitril valsartan's reduction in blood pressure is nearly about 20 millimeters in the Asians. There are about 7 studies from 2014 to 2019. And I can share the reference if you want, but it's 20 by 8 millimeter. In one study, it is 20 by 16 millimeter compared with olmesartan. So there is very good data among Asians and probably a very good drug for resistant hypertension.
And we have quoted this study also in the guidelines.
Yes, sir.
And in the final version, you can look it up. It's also quoted in the guidelines, the studies. Yeah. Important comment, yes.
Tiny, can you please start and end also, by the way?
Okay, good.
Am I audible now? Yeah, thank you. So the topic allotted is the rationale of why beta blockers have been uptrended recently in the guidelines and the clinical scenario in reference to perhaps a little bit of Indian population. Now, we know that bombs do not choose. Bombs do not choose. They will hit everything on which it falls. And there's nothing more true about beta blockers. If you look at this particular graph, is the sales revenue for atenolol, And as you can see there, if you look at the x-axis there, 2000 to 2005, atenolol sales kind of increased by 2.5 times from $1 billion to $2.5 billion, right? And that was 2005. And in 2005, the bomb fell. Should beta blockers remain? First choice is the treatment of primary hypertension, a meta-analysis by Hjalmar Lindalf, and that bombed the whole thing. In the next couple of years, atenolol sales plummeted down to near zero, right? And that was because the meta-analysis showed that if you look at stroke, when they looked at stroke, they found that beta blockers compared to placebo and other drugs increased the incidence of stroke by 16%. So it made big news. Beta blockers increased stroke by 16%. Okay, right. Now the point is, if you look at the meta-analysis in detail, you very clearly see that atenolol predominates. In fact, of the 100,000 patients data by Yarmar Lindolf, you see that 69,000 were on atenolol, and the rest, majority, were on propranolol, 22,000. And as we know that neither propranolol nor atenolol is a good drug for the treatment of hypertension. Obviously, so the headline of what did the bombing should have been atenolol. Should atenolol remain first choice of treatment of hypertension? The answer is no. So this is something like equating captopril with ACE inhibitors or lovastatin with general statins today, or equating urokinase as a standard reperfusion therapy, or talking about glibenclamide as a standard sulfonylurea, or talking about the first generation's BMS as the standard stents, right? So atenolol, yeah, obviously atenolol is not a good drug for the treatment of hypertension. Now, if we, for example, see the data, they almost look at different drugs, right? The new generation beta blockers, for example, this is a comparison of bisoprolol in red and atenolol in yellow. And we are looking at the mean change in systolic blood pressure, trying to see which is more potent. And obviously, compared to atenolol in yellow on top, bisoprolol was more effective. But that is not the point. Look at that light shaded area, the nocturnal blood pressure, significantly lower nocturnal blood pressure with bisoprolol. Yeah, what are we talking about? We know that the nocturnal blood pressure is one that tells us about the most event rate, the best predictor of cardiovascular events, and that is brought down significantly lower by bisoprolol compared to atenolol. Not just that, look at, let's say, airway resistance, right? We are talking about beta selectivity. That round clearly shows that hardly any effect of bisoprolol on airway resistance. In contrast, look at the yellow bar, atenolol, significant increase in airway resistance. Yeah, so certainly the new beta blockers are different. Look at lipid parameters. The red bar shows over a long time HDL levels with bisoprolol, and the yellow, atenolol. Atenolol reduces HDL while bisoprolol doesn't. So the new generation beta blockers, what we are trying to say, is different. They're not the kind of beta blocker meta-analysis that was done by Lindolf, and they don't truly represent the real beta blockers. And that is, but then it was like a bomb, right? The entire arena of beta blockers suffered. For example, if you look at the ESH guideline 2018, beta blockers are down there, right? You have to find out where is beta blockers. All after RAS inhibitors, CCBs, and diuretics. And what is it? Beta blockers are indicated if there's a young lady who plans for pregnancy, or somebody who has a chronic coronary syndrome, or an LV dysfunction, post-MI, or some kind of arrhythmias like atrial fibrillation. So very limited use of beta blockers, right? Look at the ESH guideline on the right. You can't even find beta blockers. They are A, C, and D. RAS inhibitors, ACE, ARB, CCBs, and diuretics. Beta blockers can't even be seen in the event flow, right? So beta blockers have gone. So that brings us to why we are talking about a beta blocker uptrend in the ESA now. So if we are looking at the ESH 2023 guideline, the ESH new guideline, couple of important points. That is level 1 and A1A. Let's see that. First thing is blood pressure lowering is prioritized. So most important is lowering blood pressure. Only secondarily, what you choose about the way you lower it, right? So the first thing is, so over the treatment benefit of blood pressure lowering is largely dependent on the blood pressure number, right? Rather than the drug you use. That is point number one. Second, they clearly said, ESH 2023, that 5 classes of drugs, ACE, ARB, beta blockers, CCB, and thiazide or thiazide-like diuretics. 5 classes of drugs could be used depending on what you want to use. So the highlights for ESH 2023 is 1, blood pressure lowering should get priority. And second, beta blockers are suddenly given back a ringside view or a seat of prestige in the VIP lounge among the other 4 antihypertensive drugs, right? So if we look into the ESH 2023 flow, you've already seen this. This has been shown to you. Yeah, you start with dual therapy. That should be a RAS inhibitor, ACE/ARB, plus a CCB, or an ACE/ARB, plus a thiazide or thiazide-like diuretic. And about 60% patients will get good control with blood pressure. If not, you add all 3, ACE/ARB, CCB, and diuretic, and 90% would be controlled. If not, you You label them as treatment-resistant hypertension and proceed for referral specialist, for further workup. But the point is, the trust is on single pill combo. On a single pill, 1 or 2 or 3 drugs on single pill, because you want the patient to be more compliant. That remains exactly same. What has changed is here. From that limited lower down indication of beta blockade, suddenly the beta blockade indication is here. Beta blockers can be now used as per ESH 2023 as monotherapy or at any step of combination therapy. So as monotherapy or any step of combination therapy, and that is a wow moment, right? People who support beta blockers, like Dr. Wise here. So, yes, it was a moment of comeback for beta blockers. And why did they do that? The ESH very clearly, if you read the document, says that number one, when compared to placebo, even first and second generation beta blockers reduce MACE and stroke, right? And when compared to other antihypertensives, they are equivalent. Accepting that it is less efficient in stroke prevention. So very clear, beta blockers don't increase stroke, even when you compare with placebo. But when you compare as a single agent other antihypertensives, they might be less efficient in stroke prevention. They are indicated in heart failure, angina, CCS, post-MI, AF, and young women who plan to become pregnant, or those who are pregnant, beta blockers, right? But that is not the point. The ESH 2023 highlights about 50 clinical conditions. Look at the graph. You can't even read them. They said these are conditions where even otherwise beta blocker does good. So if any of these associated patients have hypertension, do think about whether you need to put beta blocker in the combo. 50 clinical situations. So let us just tweeze out 2 or 3 for the Indian scenario. One would be obesity and diabetes. We all know that India is an epicenter for obesity and diabetic epidemic, right? And if you look into the Lancet data, look at that Indian graph between 70s and 90s versus 1990 onwards, we see that light small bar to the big green large bar. There's a huge jump in the incidence of type 2 diabetes and associated metabolic syndrome in India. We all know that. Now the point is, if you look at the sympathetic activity, right, by looking at the muscle sympathetic nerve activity, what we call as MSNA, and look at the rightmost bar is normotensive, yellow bar. Look at diabetic. It is more than the yellow bar, right? Look at essential hypertension. It's more than the normotension. But stop there. What is surprising is here. If you have a person with a combination of hypertension and diabetes, you see there's a significant high level of MSNA, sympathetic activity in these patients. So patients of diabetic and hypertensive have a high sympathetic drive, right? This is something that we didn't realize before. Obesity. Look at obesity. On the left y-axis, we are looking at mean sympathetic, muscle sympathetic nerve activity. And look at lean on the left, peripheral obese on the center, and central obesity on the right. Again, significant elevation of muscle sympathetic nerve activity. So sympathetic system is at overdrive in diabetic, hypertensive, and obese. So you might say, well, how do I know they're sympathetic overactive? I can't do MSNA for everyone in a simple way, and that is what Professor Ram was talking about. It is heart rate. Look at heart failure. We knew this for long, right? The y-axis, you have MSNA, and the x-axis, you have different heart rates. So if you see the quartiles of heart rate, higher the heart rate, higher the MSNA, right? It matches so well. And not just for heart failure, we know that it matches for metabolic syndrome and even hypertension. So if you see hypertension there, heart rate clearly tells us whether the muscle sympathetic nerve activity is higher or not. And that tells us about how sympathetic driven the patient is. So we look at heart rate. Now we have already seen the data by Steve Julius and Paolo Palatini, which this is a data analysis of heart rate and hypertension that looked at the data from value trial. Value trial looked at valsartan where they looked at 15,000 patients, 5-year follow-up. But what they did was they divided the patients into 1, 2, 3, 4, 5 categories. Those with a heart rate of less than 50, 50 to 60, 60, 70, 70, 80, and more than 80. Right. And when they plotted the trajectory of events, it is very surprising. There's a 5-year follow-up. And look at that. If you look at the category where blood pressure controlled, low heart rate. So heart rate is controlled, blood pressure is good. They're the best outcome, the green line, over 5 years time. But even when the blood pressure was well controlled, we are happy, blood pressure is controlled. And like Professor Ram said, how many people look at the heart rate? We don't. But if the heart rate was high, look at that, they did not do well at all. So we need to get good control of blood pressure and heart rate. Now, what they did was they took out that category who didn't do well, who had a heart rate of more than 80, and found that over 5-year period, there a primary endpoint which was 1.6 times higher. Heart failure, 2.2 times higher. MI, 1.5 times. Stroke, 1.5 times. Sudden cardiac death, 1.6 times higher. When the baseline heart rate was more than 80. Remember that number, baseline heart rate or the resting heart rate. Now, why are we talking about that? Because the India heart study, which many of us sitting here were part of it, we very meticulously looked at 18,000 patient data, almost 19,000 patient data, and we found that the Indian hypertensive resting heart rate was 83 beats per minute, average heart rate. So unlike the Western population, we see here that Indian hypertensives have a fast resting heart rate. This is the first study which showed that yes, we have a faster resting heart rate and how this heart rate could be a factor in determining how we choose our therapy. Right, so we are sympathetic driven, and that is clear. Now, this is a very beautiful editorial written by Dr. Takuya Kishi from Japan, Fukuoka, Japan, and she draws a beautiful, beautiful diagram where you see hypertension with a heart rate of less than 80 is a lower sympathetic activation and very clearly have a low cardiovascular risk. But those hypertensive on the right, when heart rate, resting heart rate more than 80, have a higher sympathetic activation and a cardiovascular risk. And the editorial says that this is a group where you need to consider beta blockers. I mean, just trying to see why beta blocker got back its seat, right? Finally, look at this. We know that today, like we showed, diabetes, metabolic syndrome, and obesity is at the center stage. And adipocytes release angiotensinogen, which is converted by renin secreted by the kidneys to angiotensin 2, and that's why we use an RAS inhibitor, right? But the point is there's something we were missing out right on top. And that is, this is driven by sympathetic nervous system, SNA, both driving the kidneys, and that's why we know today that's how the renal denervation works, and of course to the adipocytes. So we need to inhibit angiotensin 2 by ACE-ARB, but we also need to inhibit sympathetic nervous system with a beta blocker. So this combination is likely to be the drug of good combination ideal for the Indian metabolic driven person. Now there's a small hitch, right? You might say, okay, what about ACE or ARB, RAS inhibitor? RAS inhibitors, in a very interesting trial which came recently, look at that, eprosartan is ARB, right? So they tried looking at eprosartan. Look at that. The left set of graph is placebo, right set is eprosartan. On the left, you have muscle sympathetic nerve activity. On the right, you have norepinephrine level. Right. Now, focus on eprosartan. The muscle sympathetic nerve activity on exposure to eprosartan, despite control of blood pressure, became higher than control. The norepinephrine levels with eprosartan became higher than placebo. So ARB is basically controlled blood pressure, but they hike up muscle sympathetic nerve activity and norepinephrine levels. And that is important, which means just by giving a RAS inhibitor, look at that one patient data. This is one patient. See on top, the sympathetic, muscle sympathetic nerve activities. Look at those spikes, few, but look at the bottom one, multiple spikes. Okay, placebo versus eprosartan. Now, they were crossed over, and look at that. The moment they went over to placebo, the spikes decreased. While iprosartan crossed over the placebo, again increased. So clearly, ARBs and RAS inhibitors tend to slightly upgrade sympathetic nervous system. So that is why we are today talking about combination of beta blockade and ACE inhibitors. Yeah, in multiple situations, we say that this is over the cardiovascular continuum. Today we say that beta blockers and RAS inhibition will be good for hypertensive with faster heart rate. It should be good for people with chronic coronary syndromes. It should be good for people with recent MIs. Should be good for people with AFib. Should be good for people with heart failure and LV dysfunction. So multiple areas we see that combination of beta blockade with RAS inhibition might do us a favor. So finally, what are we talking about? We are talking about this. Anxious, white coat hypertensive, young, working in the IT. We just talked about them. A post-MI, a lady who is planning pregnancy, obese, hypertensive, where we don't realize that they are sympathetic driven, LV dysfunction and hypertension, migraine and hypertension, very many other diseases, including CLDs and hypertension, and of course, a chronic coronary syndrome. Multiple of these indications today tell us that yes, there's an uptrend in the prescription of beta blockers simply because they're useful and they're indicated. And only thing, the guidelines have today come forward and said that yes, intelligently choose beta blockade and add them at whatever level you want. Thank you for your time and attention, and I'll give back the podium to Professor Ram.
Thank you, Tiny. What we will do is, we'll still finish on time, but we will somehow adjust the speed and velocity of our comments. One comment, I'm coming to the panelists next, is Dr. Grassi. I see him. The world guru on heart rate, sympathetic nervous system. He's the current world guru. Can you make one or two remarks on Dr. Tiny Nair's talk?
Well, sure. I think that the last intervention was very clear in suggesting the need for treating sympathetic overdrive in hypertension, particularly in young or middle-aged patients, first one. The second one is the central role, and European guidelines, the last version made very clear, the need for having back beta-blocking agents as a first-step treatment, particularly in the group of patients in which we suspect or we have indices of sympathetic overdrive. In other words, I think that doctors during medical visit should pay attention not only to blood pressure, but also to heart rate. And this will be the main message, because elevation, if increase in heart rate, is something no good for the cardiovascular system. And in specific cases, such as hypertension associated with elevated heart rate, the use of beta-blocking agents is fully indicated.
Thank you. So let me assure the so many audience that we are coming to your questions very shortly. And if I can have our panel discussion started, if we can, I'm going to introduce our expert panelists in their alphabetical order so that I'm politically correct. Dr. Rajan Isaacs, I hope he has joined. I didn't see his thing. Is he there? No,
Yes,
I have.
yes, I'm very much there, and thank you very much for letting me a part of this discussion.
Right. Rajan Isaacs is a very prominent nephrologist with interest in hypertension from Christian Medical College, Ludhiana, which is one of the oldest medical colleges in India, and it is one of the several medical colleges which did not accept me when I applied. for medicine. So you can add that also to the list that I was rejected by Christian Medical College, Ludhiana. And this is the truth. Not only he graduated from one of the topmost medical colleges, and then he did his post-graduation, additional post-graduation at All India Institute of Medical Sciences. Then he came back to Ludhiana and heads the Department of Nephrology, Hypertension, and a lot of experience in clinical and academic nephrology. And I'm glad that he's participating because there are some renal associated questions. Dr. Prabhakar is one of our other panelists, and he already has taken an active role in today's program. I know him personally. He's an excellent clinician, excellent academic person in Chennai, and he has participated in a number of academic programs, both education and research in India, and continues to do that. He's an active member of the Cardiological Society of India, American College of Cardiology, and also he participated in the recent guidelines document of the Indian Society of Hypertension. It will be interesting to see his views. In addition to hypertension, he's actually interested in cardiometabolic disorders because he does work on lipids also. Next is Dr. Soumitra Ray, a good colleague of mine. I always call him not Soumitra, but Hazar Mitra Ray. So he's a friend of thousands of people, both in Calcutta and elsewhere. He's one of the prominent clinical academic cardiologists in India and in Calcutta in particular. And he's presently the head of interventional cardiology at the Advanced Medicare Research and Institute Hospitals in Calcutta. Before that, he was at Vivekananda Institute of Medical Sciences. He is a graduate of Calcutta Medical College, both MBBS and MD. Then he did his post-graduation in UK. He's a Master Royal College of Physicians. He's on the editorial board of several journals. He's an excellent clinical cardiologist, one of the few cardiologists who has a genuine interest in hypertension. And I can say that. So we have an excellent panel. What I would like to do is I would like each panelist to make a brief comment on the previous talks. What Dr. Mansia was going to conclude in the resistant hypertension was that most of the cases are due to underdosing of optimal therapy. That's what he was going to do. And then he was going to suggest that you control the volume. However you want to control the volume, you control the volume, and that might reduce the blood pressure. And in patients who have truly resistant hypertension, some of them might need a workup to uncover a secondary cause of hypertension, which is all covered in the guidelines. That is what he was going to show in the slides. Now, what I will do is I will reverse the order for people to comment. I will ask Dr. Ray to make brief comments on these talks, and then Dr. Prabhakar will make brief comments, and Dr. Isaacs will make brief comments, and then we'll go to the discussion, and I have this lined up. Please, Soumitra, please give your expert comments on the program so far.
Thank you, sir. Thank you for the kind introduction and the program. Of course, so many things have been covered. I should not comment on all of those because that not permitted by time. I'd limit myself to the hypertension in the young aspect, which I think was a bit under discussed because of lack of time and focus. As you know, sir, about 5 years ago, there's a publication from India that the young school-going children, which was studied in 4 states of India, around 20 to 25% of those children between the age of 12 and 15 are already hypertensive by the adult criteria. That is 140/90 blood pressure goal. And that is a very, very shocking news to all of us. And 40% of those children were obese. So obesity perhaps is a very important cause along with other lifestyle changes for a young hypertensive. So 18 years cutoff for checking the blood pressure is the bare minimum we can do for India and other countries. So check the blood pressure at the age of 18. And you also asked at some point that who is the youngest heart attack I found. It is a 22 years old man who had a clear-cut heart attack, but he was a cannabis user. So I think the drug users, particularly the cannabis type of drug users, are a group of people who suffer from early coronary disease and hypertension as well. Of course, familial hypercholesterolemia is an important cause of early heart attack. The second point I would say in young hypertensive is that, of course, the secondary causes become more prominent as the age of hypertension decreases. But still, by any study, it is not more than 15 to 20%. Maybe it is 5% in elderly, but not more than 20% in younger patient, you get a secondary cause. So still there are 80% of young hypertensive whom we do not know the cause. And the last point I would make, sir, 30 years ago, the study was published that hypertension is basically either volume related or RAS related, RAS or sympathetic together related. And we give a combination of the two types of medicines because in most of the cases, we do not know what is the primary pathology in a person's hypertension. So, and it was shown very clearly that in a high PRA patient, if we give diuretic, it does not work at all. And in a low PRA, if we give RAS blockade, it does not work at all. So do we think in future we should be more precision medicine to find out the pathology of hypertension, at least the primary pathology, and to make the number of medicines lesser and lesser rather than more and more, as shown in the recent quadruple trial, quadrate trial. You are giving 1/4 drug of 4 medicines together to begin with. Of course, that is a blind treatment because we do not know the pathology and we are trying to attack all the pathological mechanisms. It's just a provocative thought whether we should be practicing more precision medicine in future and rather decreasing the number of medicine rather than increasing the number of medicine. That's my submission, sir.
Thank you, Soumitra, and we'll comment on it. Dr. Prabhakar just cleaned his glasses so that he can have a clear vision of whom he is looking at. So I want him to comment on the previous talks and then Dr. Isaacs, and then we'll go for the questions very quickly. Prabhakar.
Thank you, sir. Thank you, sir. Thank you for the excellent opportunity. I think I should first congratulate the 3 speakers on excellent talks. I think the contents were great and very good complementary talks from Professor Guido and Dr. Tiny. I think that was a very, very important message stating that the heart rate of 80 is very, very important in Indians, especially where the resting heart rate is quite high as denoted by the Indian heart study or Indian hypertension studies. I think that was one of the very important messages. And we have been using beta blockers. In fact, we have been conducting a registry in Tamil Nadu, and we have found out that nearly 85% of the patients who are on more than 3 drugs for hypertension are actually on beta blockers. We are yet to publish that, but the data is being collected. So we'll come to that later. So I think heart rate has been neglected. And I think perfectly Dr. Guido came up and said that 80 is the rate. And that's very important because the previous only guideline which was talking about the heart rate was the NICE guidelines, which said that 70 was significant. But I think there is more evidence to say that 80 is significant. And the NICE guidelines actually said that if you're after the 3 drugs, look at potassium less than 4.5, use MRA. And then if it is more than 4.5, look at the heart rate. If it's more than 70, start using beta blockers. I think it's now very, very clear and very important for all of us to understand the importance of beta blockers. And I think today's session is made good because of the significance of beta blockers. The second point about Professor Kreutz is I think he made an excellent comment on elderly hypertensives. And the whole scenario has been beautifully mentioned. And I had very few points to add to that. One, I think, was the point about the goal for hypertension. I think this guideline with Professor Kreutz as one of the very important writers in that important contributors has said that the goal systolic blood pressure is going to be 120 to 140 and the diastolic between 70 and 80. I think which is very, very important because so far we only had one number as 130-80 or 140-90 as goal. I think this is a beautiful statement that is made, and that picture that you showed with the green, red, and the yellow there, that I think is as a very important message. And I think that should be stressed again and again during all our meetings, sir. And I also wanted to say that with resistant hypertension, Professor Grassi was not here. There are a lot of interesting data. One of the interesting data is a comparison between spironolactone and finrenone. the fidelity data was compared with AMBER, and they found out that it was only the MRAs, the steroidal NRAs in terms of spironolactone that worked in resistant hypertension. The data in fidelity in resistant hypertension was not as effective as spironolactone. And in a patient who is on resistant hypertension, the double diuretic therapy, which is what the pathway trial said, is very important because the salt and water retention is predominant in these patients. And this goes away once you start getting to 5 drugs. That is the refractory hypertension. Because I think it is not stressed much. I think probably Professor Krutz can take the cue and next guideline add one more section on the refractory hypertension also, where the pathophysiology is important. I think there has been enough stress on the obesity and the OSA also, and alcohol also has to be stretched because a reduction of alcohol intake has been significantly implicated in the reduction of resistant hypertension. I think that's fair enough time, sir. Professor Ram.
Thank you, Dr. Isaacs. You need to unmute yourself.
Yes, I have unmuted. I just wanted to make a comment that refractory hypertension, the true refractory hypertension has been mentioned after removing all the secondary causes for high blood pressure. Now, if you see the data, bulk of the patients who present to you with refractory hypertension have chronic kidney disease at the background. So you have basically removed the secondary hypertension, CKD, from the true hypertension. That is one thing that is a little confusing because we see resistant hypertension fairly frequently. And in spite of all the 3 drugs, the blood pressure continues to remain high. And in our experience, basically beta blockers, if you add beta blockers, that is the cornerstone for really bringing down the blood pressure. So what has been discussed by Dr. Nair and the rest of the faculty, that beta blockers are a very important drug in management of refractory hypertension if you really want to get the thing. And secondly, renal artery stenosis is something that one really needs to look in patients with CKD, and especially in a scenario because CKD is associated with heart failure, and the risk of renal artery stenosis is very high. So a word of caution, where we use ACE inhibitors and there is a drop in GFR by more than 30%, we must evaluate our patients for an underlying renovascular hypertension. By and large, I really don't have much to add, but this is what I felt during the discussion.
Thank you. And we'll just go to, I want everybody to stay for a few more minutes. There are some questions. There are 2 questions that came from last month's Zoom conference we had. And actually, Dr. Manchia was going to comment on those. But he's unable to join due to technical. In fact, he told me he was going to comment on those things. One is about calcium blockers in treatment of hypertension. Calcium blockers remain an important option in the treatment of hypertension. And he was going to say that new generation calcium blocking drugs might have advantages over and beyond blood pressure control, particularly in terms of renal protection, proteinuria, lack of ankylodema, etc. And India is very fortunate. He was going to say that you have new generation calcium blocking drugs which are effective and which are also protective for the heart and the kidney. And then there was the current role of diuretics. The European Society of Hypertension guidelines have commented on the importance of thiazide-like diuretics also. Little bit broader statement this time than before. So the thiazide-like diuretics which are available in India in low dose, they do fit into the current guidelines. These are the comments that he was going to make from previous Zoom call. Now, there is anybody can comment. I can ask one of the panelists to comment. Target blood pressure in treating hypertension in pregnancy. There is actually a section in the new guidelines on hypertension in pregnancy, like any other guidelines. Can any of the panelists raise your hand and comment on what is the target blood pressure to treat hypertension in pregnancy? And by that, I think they mean preeclampsia type of the classification of hypertension in pregnancy. They're not talking about chronic hypertension in pregnancy or postpartum. Pregnancy-induced hypertension, which is a temporary phenomenon. So anybody volunteers, don't worry, you're not going to fall down. You're not on a stage.
Venkata, if I can comment if you wish.
Yes.
I think the key question is an important question. First of all, we have a whole section on hypertension disorders in pregnancy in the guidelines. Also other aspects important for women, but in pregnancy, the key question, I think, is what is the threshold for treatment?
Right.
That's the key question. Target is not so well studied. The key question is the initiation, and it is again that I think it simplifies the approach. Is the threshold is like the definition of hypertension is the same, 140/90, either in patients with existing hypertension or hypertension-induced associated pregnancy-associated hypertension. There's a safety recommendation, which is that the blood pressure, the diastolic blood pressure, should not be lowered below 80. That's a safety to maintain confusion. I think these are the two. For me, Dr. Ray, if I see that you're also commenting, I think the key question is the definition, when to start. Also, there are some controversy in different guidelines, but we have we recommend 140/90 and a safety margin with regard to maintain perfusion, not to go below 80. Do you agree, or what's your take on this, Dr. Ray?
Soumitra.
Okay, yeah, I think it's absolutely okay. 140/90, and we should not go below perhaps 130/80 because of chance of hypoperfusion and IUGR, intrauterine retardation. And another part of the question, as Dr. Ram said, that traditionally we used to give methyl dopa and labetalol. These are the two traditional drugs which are used for pregnancy. But nowadays, I think we have got proven safety and recommendation on beta blockers as a drug of choice in pregnancy. Labetalol is, of course, is a part of alpha beta blocker, but beta blocker purely and amlodipine itself is also very commonly used nowadays. And we are more accustomed to use amlodipine rather than methyl dopa as a general cardiologist. But of course, the RAS blockade is completely contraindicated, any form of blockade. So actually, that is
actually, in our countries, in our regions, for instance, the predominant drugs used are CCBs and beta blockers and alpha methyldopa. For instance, labetalol is not available. It's from the market, and because of hepatotoxicity. And there was even a recent case report, even hepatotoxicity induced in the women in pregnancy using labetalol.
Can I comment on that? The alpha methyl dopa is not available in India. Labetalol is available, so we use labetalol more freely. And among the beta blockers, metoprolol is better than atenolol. So metoprolol only can be used, not the other drugs.
Yes.
Prabhakar, you're right.
Can be given.
The International Society of Study of Hypertension in Pregnancy and the last American Heart Association guidelines for hypertension in pregnancy, they would suggest labetalol. And you're right, methyl dopa is very, very erratic, with all due respects to Dr. Krutz, who is actually, in addition to hypertension expertise, he's head of the clinical pharmacology, he knows about it. Now, this is something that anybody can comment about mineralocorticoid antagonists causing hypercalcemia. I have seen, or I have not seen, I have heard that spironolactone can increase ionized calcium and can decrease PTH. I have seen, but what is the significance? I do not know. But there are little bit reference to this high calcium and low PTH, but I do not know the significance of it, whether this is temporary or anything. Anybody has knowledge about it? Because Dr. Shahid from Prayagraj, UP has asked this question.
I think we have a nephrologist, sir. I think he'll be the right person to comment on this. Dr. Rajan,
Yes.
You conveniently passed the buck. I don't think it
Very
is
true.
very significant. And it really, I have really not come across any such cases in my experience. And it has never been a real clinical problem. So I think it is more of an academic situation. And since I don't have much experience in such a situation, commenting may not be appropriate. But in my experience, spironolactone, my major limitations have been with menstrual irregularities and gynecomastia, that people are more bothered. In fact, I have not seen very many people monitoring the calcium levels and IPTH levels when we are using spironolactone. So,
I
I
think
mean,
the
at this
gentleman
stage, I
wanted
will
to
not
know
be able to comment.
hyperkalemia. There is a typo. He wanted to know because he said as the dose increase hyperkalemia, he misted.
So hyperkalemia definitely is something that we have to be careful about. And once the potassium levels go around 5 or a little above, we need to preferably look for reasons for hyperkalemia apart from the drugs, and go for a stricter diet control, and maybe modify the drugs. And there are special leaching procedures for vegetables and dietary precautions that can be taken care. Then there is use of patoromir and zinchromium. Unfortunately, they are currently not available in our country, but that would definitely add to the treatment armamentarium. And we will be able to use ACE inhibitors and MRAs to a greater degree as per the guideline-directed treatment.
Okay. Now, one comment on Soumitra Ray. He has taken back to John Lara and Hans Brunner and Bueller, volume and renin as a basis. Soumitra, unfortunately for some thinking, it's not needed anymore, because all the guidelines recommend combination therapy. When you have combination therapy, the age, the gender, and the volume, renin status does not play any role. And moreover, one does not do renin anyway for routine
Everything
treatment.
is taken care of. That's true, sir.
But you're right. Hopefully, like cancer that we have, and some types of pulmonary diseases, hopefully there will be some precision medicine in the future based upon the profile of the patient rather than the renin-angiotensin system or volume, because we don't measure volume and we don't measure renin-angiotensin system. Sure. One comment I have on heart rate, which always is talked about, there are guidelines for blood pressure, there are guidelines for lipids, and there are guidelines for obesity, and there are guidelines for diabetes, but there are no guidelines for heart rate. So when you don't have guidelines for heart rate, people don't look at heart rate as something that they should be doing unless somebody is complaining that my heart is coming out of the chest, you see. So until, I'm not saying that we need to increase the medications, until there are guidelines for heart rate, it remains a part of discussion, but rarely as a target of treatment.
So two quick comments. One on heart rate. It's very difficult to get the baseline heart rate in a busy clinic. When the patient is stressed and there are so many infrastructural problems, I really do not know whether that 90 per minute is a real value for that person if he is in his basal state, because these are all basal heart rate we talk about. How do we get a patient in his basal state? And second said Dr. Isaac's comment, two very important food in India cause hyperkalemia, which we ignore. One is the rock salt or K salt. Most cardiac patient, hypertensive patient think that rock salt, K salt is the important thing and you should not take the normal NaCl. That is a very wrong concept and that causes hyperkalemia. And second is jaggery, is very common food in India, which is loaded with potassium and is often a cause of hyperkalemia. So a person who is prone to have hyperkalemia, we should tell them remove the rock salt and jaggery from your kitchen.
See, I absolutely
comment
agree
about the
with
heart
you.
rate. Dr.
Just-
Venkatram.
yeah.
PC has a comment on heart rate. And
Me too.
Isaac has a comment
Is it important to look at the resting heart rate or response of heart rate to exercise? I think that is more important.
Absolutely, sir. Just a random heart rate check in the clinic doesn't mean anything. That is my point.
But PC, an ordinary practitioner taking care of patients in the clinic, not your clinic, but why would they want exercise-induced heart rate? Why would they want to get it?
No, the resting heart rate is a physiological phenomenon. Some people it's more than may not be anything. By restricting the heart rate, maybe we are doing harm. Normal, it may be a resting heart rate. Somebody is 80, somebody is 90, somebody without any other problem, or not with hypertension, anything. Just restricting reducing the heart rate may not be a good idea. But those who are with minimal exercise, heart rate inappropriately goes up. Maybe those are the people who probably may be benefited if you reduce the heart rate by using beta blocker. But as such, somebody comes to a clinic, his heart rate is 80, he's not having hypertension, nothing, you don't have to bother about it.
Okay.
I don't too much emphasis on hypertension, heart rate, resting heart rate, especially. I'm not very sure. There's not much.
Sir, one of the important plus points about the apparatus.
Dr. Isaacs is going to respond to Dr. Ray, and then we have a couple of more questions.
Yes,
and
I just wanted to add to what Dr. Ray is saying. The first thing that we do for all our patients with CKD is ask them what kind of salt they are using. Because of this high-powered media promotion, most of the people are using this low sodium diet.
Yes.
And that is very rich in potassium. So the first thing that we do is stop the low sodium diet and ask them to go back onto the regular sodium chloride salt consumption. And jaggery is a stable food, this thing for a lot of people, and that definitely has to be informed that you need to stop this. So you're very right in pointing these two facts.
Okay, thank you. I know Dr. Prabhakar, when he mutes or cuts off his video, his profile picture comes. In his profile picture, he looks like either Rajnikant or Kamal Hassan. He does not look like Prabhakar. That profile picture that you see.
When my signal goes down, I cut the video, sir.
Okay, now I have one comment on Tiny Nair's. I know iprosartan is not used in India, but Dr. Krutz is a clinical pharmacologist. Therefore, I am going to ask Tiny Nair that particular study, small study, which is very surprising, that it showed an increase in sympathetic tone with iprosartan. Absolutely. Because iprosartan actually blocks presynaptic AT1 receptors. When you block presynaptic AT1 receptors, you block non-adrenaline release. So it is like a sympathetic blocking drug. Yet you showed a paradoxical increase in sympathetic nervous activity. Please comment, and then I want Dr. Krutz, our clinical pharmacologist par excellence, to say a word about it.
Generally, as you said, sir, ACE and ARBs are supposed to be heart rate neutral, sympathetic neutral. But then somehow, this was the first study to show that iprosartan increases sympathetic activity. This was followed by quite a few editorials and comments and further smaller studies again, but clearly showing that ARBs tend to accelerate sympathetic nervous system. See, our knowledge about sympathetic nervous system is very small, but this is not a stray trial that has shown. Generally, today, researchers believe that by some mechanism, RAS inhibitors tend to upgrade sympathetic nervous system. Exactly how? Maybe Professor Krutz can tell us.
Okay, because they have a good outcome study. Moses will not talk about it. It's mostly European study. Reinhold, you want to comment? I know iprosartan is not used in India, but still, since it was shown, what do you think of this paradoxical increase despite its pharmacological effect on inhibition of non-adrenaline?
Yes, I'm happy to comment on this. First of all, you very nicely explained already the mechanisms here. So we have a connection between a loop between the sympathetic nervous system and the renin-angiotensin system. The very famous one is beta-1 receptor renin release, sympathetic drive linked to the renin-angiotensin system. And the other one is presynaptic AT1 receptors, as you mentioned. Eposartan, I know these are friends, Roland Schmieder and Schobel, very small study, provocative study, could be related to the unique pharmacology of eposartan, shorter half-life. We have two ARBs in common use, even though eposartan is not in common use, that have a different structure. Telmisartan has a different structure, has not a tetrazole moiety, and eposartan has unique structures, a unique molecule. Maybe it's related to that, central mechanisms and short-term effect, I don't know. I think we may all agree all studies, huge studies that look into heart rate in clinical settings in response to RAS inhibition did not show a significant increase in heart rate. I think they are clearly neutral. So this is a small suggested study, but maybe a unique phenomenon, physiological study to eposartan. So I'm not convinced that RAS blockers do really increase sympathetic nervous system systemic activity. I have also maybe a short comment, if you have still time, 15 seconds on heart rate. I think what we recommend, and if possible, we need an ECG in all patients. For two reasons. For screen, it's not sensitive, but to screen for left ventricular hypertrophy, it's very predictive if you detect it. Very predictive prognostic. We need also an ECG in resting position for AV interval when we use beta blockers to look out on the rhythm, and we get the heart rate. And you mentioned that we don't have a guideline for heart rate, but we have a leitmotif for heart rate in the guidelines. First, mentioning, as Professor Grassi mentioned, largely due to his studies, heart rate above 80 BPM is a potentially risk factor, or and this, whatever you mentioned, a factor contributing to increased risk. And we have also two recommendations, where heart rate is a differential parameter. It's in patients with chronic coronary artery disease, when to use beta blockers and other drugs. We have this figure, and also for atrial fibrillation. It's not very clear with the strong evidence what's the optimal heart rate in atrial fibrillation, but we state that in hypertensive patients, per se, the heart rate target is 80. It applies to coronary artery disease, coming up with the beta blockers, and also for heart rate control in hypertensive patients with atrial fibrillation. So we have two figures and recommendations where the heart rate is specifically introduced and also in our guidelines.
The whole purpose of presentation was that, RAS inhibitors per se don't clearly inhibit sympathetic system. And in very many symptoms like diabetes, metabolic syndrome, and obesity, you accelerated both sympathetic system and renin-angiotensin system. So ideal would be combining both inhibitors so that you get best target organ protection.
That's a valid point. And a beta blocker is a weak inhibitor in the RAS system, but the RAS blockers are not strong inhibitors or inhibitors in the sympathetic nervous system. Yes, that's a very valid point. Yes, I agree.
Yeah, only thing tiny Dr. Schmieder, who is known to European, he's the one who discovered that AT1 inhibition by eposartan is actually sympatholytic rather than sympathoexcitatory. But a small study doesn't matter because it's not widely used. Not many patients are at a risk from tachycardia from eposartan in India.
Yes.
Sir, may I draw a sorry. So may I draw an analogy with the calcium channel blockers, like cilnidipine, benidipine, etc., which are working on L and T channels? They are actually reducing heart rate, whereas amlodipine working on L channel is neutral for heart rate, and short-acting nifedipine by vasodilatation causes reflex tachycardia. So by the duration of action and channel used, the same group of medicine can have different effect on heart rate.
Right.
Yeah.
Now, that's well known. Now I'll comment because there was a question on the dosages of calcium blocking drugs. And the question on the new generation that you mentioned, some of them, what is the dosage of azolnidipine? I know nephrologists like to use up to 32, but I feel that 8 to 16 is the dose that has been studied, in my opinion. I know nephrologists, they don't worry about any dosage of anything because they can always dialyze the patient. So that's a different question. And then the dosage of the diuretics in India, hydrochlorothiazide is not available in 25 milligram, although it was the one that was used in the diuretic comparison product study. It's not available in India, but the low dose chlorthalidone is available, 6.25. 12.5 was used in the diuretic comparison project. So that's a comment I have on this. Isaac, Rajan, you have anything to comment?
No, I don't agree that we go to 32 milligrams. We don't exceed more than 16 milligrams.
Okay. I have heard some of your colleagues say they go up to 32. I don't know.
And if we start dialyzing them, then I don't think it's justified because there are different stages of CKD, and it's only for 5 we start dialyzing them.
Oh, okay. Then I think nothing has popped up. We express our thanks to all the speakers, particularly from Europe, for the early morning. And then we certainly thank our chairpersons, Dr. Grasai and Dr. P.C. Rath, for participating in the session. And all the speakers did a fantastic job. And I also thank Dr. Parikh, our clinical pharmacologist, excellent clinical researcher, for starting the program because he's got a big knowledge about the drugs. And one of the few people in the research departments in India who actually writes papers quite often by himself, and it's a very important contribution to it. So if anybody, if you don't want to take any shots at me or arrows at me, then I could conclude the program by asking somebody from our organizer. We have one more program next month. Sachin Nair, if you can kindly give your vote of thanks, and then you will conclude the program, please.
Good afternoon to all the faculties and doctors who have logged in from across India. It was indeed a great academic extravaganza. My heartfelt thanks and gratitude to Dr. Ram sir, who had been a good moderator and moderated entire sessions. My heartfelt gratitude to all the ESC core members, Dr. Grassi, Dr. Mansia, and Dr. Ronald Cruz for giving elaborate talk. My sincere thanks to our chairperson, Dr. P.C. Rath sir, who has taken his valuable time to come and be over the part of this program, and Dr. Time Nair sir, who had given excellent talk. And my sincere thanks to Dr. Soumitra Ray, though he had a busy schedule, still he had come for this program, and Dr. Pravakar and Dr. Rajan Isaac sir. So my heartfelt gratitude to all the speakers who have been the part of this program. In fact, sir, we had 2,700 logins, and we had 19 places where there was a live hybrid program was going on. In fact, there was one program currently going on in Patna, CSI Patna, where this program is live streamed now. Also, so I would like to thank all the doctors who are physically present in the hybrid CME. Dr. Ranga Manikandan from Madurai, Dr. Yar Rungunathan Coimbatore, Dr. Deepak Saha, Dr. Vasantan Kumar, Dr. Kapil Bhargava from Udaipur, Dr. Mohammad Shazid from Allahabad, Dr. Sarit Suryavanshi, Raipur cardiologist, Dr. Sham Joshniwal from Lathur, Dr. Narayan Devagar, Dr. Asutosh Sonawane, Dr. Manoj Chitle, Dr. Aishwarya Desai, Dr. Ravindra, and Dr. Rajiv Kishore from Agra, Dr. Sudhir Kumar from Gorakhpur, and Dr. Mandir Singh Ludhiana. Thank you very much, sir, for your valuable time. We really appreciate your contribution. I'm sure this program will really help all the doctors across India to have their practice enhanced with this program. Thank you very much, sir. Thank you very much.
Thank you very much, doctors.
They say it's last but not the least.
Yeah.
But PC Rath, there is a question to you. not for anybody, to you. Don't mention any guidelines, don't mention this reference, that reference, don't do that. Your goal in treating hypertension in your patients with coronary artery disease, your goal in treating hypertension in your patients with congestive heart failure, your goal.
Yes, first it's, I think besides reducing the blood pressure to 130/80, I want the heart rate to be reduced. That is more important. And because patient is a CAD, heart failure, I think heart rate reduction is the most important thing, besides reduction of the blood pressure. And I'll prefer the reduction of the blood pressure a little lower. I'll prefer that 130/80 range. That is my preferred treatment.
Okay, I think with those things, we'll conclude with reasonable time, a little bit extension which happens these things, but still I think we tolerate and we forgive each other, which is very important. And thanks for everybody, and you have a good afternoon and good evening, and see you or talk to you soon. Take care. Bye-bye.
Bye-bye.
Thank you. But Venkatraman, what is the time there now?